Bismillah ar-Rahman ar-Rahim. My name is Mohamed Taman. I am a lecturer of obstetrics and gynecology at Mansoura University Hospital. Today we will talk about postpartum hemorrhage. During our discussion, we will try to cover all of these topics. We'll have an overview about the postpartum hemorrhage definition, the causes, medication that could be given during postpartum hemorrhage, and how to manage patients having this main problem. The definition of postpartum hemorrhage as regard the recommendation of the Royal College of Obstetrics and Gynecology is divided into primary postpartum hemorrhage and secondary postpartum hemorrhage. And for primary postpartum hemorrhage, you should have loss of at least more than 500 milli of blood or more of blood during the first 24 hours after delivery of the baby. And again, this is according to the Royal College recommendation of definition of postpartum hemorrhage. And we have the secondary postpartum hemorrhage, and this happens after the first 24 hours, and it could be extended for 12 weeks after delivery. The Royal College also classified this postpartum hemorrhage into minor and major problems. This minor postpartum hemorrhage could happen when you have losing of about 500 up to 1000 milli of blood, and if you are losing more than 1 liter of blood, it's called major postpartum hemorrhage. This major postpartum hemorrhage is subdivided again into moderate and severe attacks. This moderate attacks happens if you are going to lose between 1 liter up to 2 liters of blood, and it will be a severe attack if you are going to lose more than 2 liters of blood. For the incidence of postpartum hemorrhage, most of cases will happen in about 5% after vaginal delivery and about 10% after cesarean deliveries. And this differs between between centers according to the experience and the maternity care in each center. If you are going to talk about the causes of postpartum hemorrhage, you have to focus in these 4 T's. These are very famous 4 T's. There may be a problem in the tissue, in the tone, or there may be a trauma, or there may be a problem in the coagulation profile, which is the thrombin. By the tissue, I mean something like retained placenta. By the tone, I mean atonic postpartum hemorrhage. By the trauma, it's called traumatic postpartum hemorrhage. And in the problem in the coagulation profile or in the thrombin, it is called the coagulation disorders. Again, these are examples of these 4 T's. This is anomalies in the uterus, and this is the retained placenta and subinvolution of the uterus, and this is the disseminated DIC, which is the coagulation defects, and there may be a tear in the cervix, vagina, or in the perineum. These are the risk factors that may lead to these problems. If you have patients having multiple pregnancy, there will be a problem in the tone. If there is a previous history of postpartum hemorrhage, if there is a preeclampsia, is a risk factor of occurrence of DIC. Fetal macrosomia, the risk factor for occurrence of atonic postpartum hemorrhage. Also, placenta accreta is an example of the risk factor of the retained placenta. And if there is lacerations in the perineum or in the genital tract, there will be an example of the traumatic postpartum hemorrhage. If you are going to diagnose patients having this problem, you have to think in the general examination, abdominal examination, and local examination. Most of these patients will have different clinical picture according to the amount of blood loss. If you look in this picture, most of these patients will have signs of hypovolemic shock, especially if there is a loss of more than 2 liters of blood, and especially in a short duration. There will be pallor, sweaty forehead, cold extremities, rapid weak pulse, hypotension, rapid and shallow respiration. If you are going to examine the abdomen of the patient, you will find that the uterus is soft and flabby in atonic postpartum hemorrhage. However, it will be hard in cases of traumatic postpartum hemorrhage. If you are going to inspect the genital tract, you will find that there is laceration in the genital tract or an external bleeding from the genital tract. There may be a mass protruding as we will see in the coming slides. We should almost always put in our mind that we have to differentiate between the atonic variety and the traumatic variety of this postpartum hemorrhage. And the most differentiating points between both of them is the consistency of the uterus. And if you found that there is a flabby uterus, you are trying to think in the atonic variety, and if it is hard and will contract the uterus, you will think in the traumatic variety. The second step is to try to investigate your patient, and the most important thing is you should have these laboratory investigations. Should have CBC, full laboratory investigation, and you should be ready for cross-matched samples and coagulation profile for your patients. And then you may be in need of doing this ultrasound. This ultrasound will show this retained product of conception that is seen inside the uterine cavity, and it could be a part of the placenta. And this is the second tool of investigation that you can use. During your management, you have to think in 2 points. We have to prevent the occurrence of postpartum hemorrhage, and we have to treat postpartum hemorrhage if it happens. For prevention, this is an antenatal or antepartum before its occurrence. We should almost always keep our patients having hemoglobin level more than 10.5 grams per deciliter, and this is a recommendation by the WHO to correct anemia. For most of patients, we should use centometrine, and this is for prophylaxis of postpartum hemorrhage. You should inject intramuscular 5 international units of centocinone and 0.25 milligrams of ergometrine. And we can use this drug, which is called carbetocin. Carbetocin is a drug like oxytocin, but it is a long-acting oxytocin receptor analog. It acts on the oxytocin receptors, but with longer duration. It extends up to 2 hours. Then you have to empty the renal bladder, and you must do this active management of third stage of labor. And for this active management, you have to use oxytocin to do early cord clamping and to do branded Andrews maneuver as shown in this figure. You have to put your hand in the suprapubic area and going to push downwards and upwards, and you have to do counter traction on this cord gently, waiting for the signs of separation of the placenta. And you can use also misoprostol, and this is a prophylactic dose of misoprostol, which is a prostaglandin analogs. This is between 200 up to 400 micrograms. You can inject oxytocin also in the umbilical vein, and you have to do exploration of the uterus and the birth canal after you finished. Again, this is for the prevention of occurrence of postpartum hemorrhage. For the treatment of postpartum hemorrhage, you have to know it is done according to the degree. Either it is minor or it is major attacks of postpartum hemorrhage, and you should almost always think in the resuscitation of your patients. And for this resuscitation, you have to choose between both of these cannulas. Again, remember, this is a unique colors of these cannulas in unique colors worldwide. This yellow color is for neonates, and this one is suitable for infant, and this is for adults. And this purple color and this pink color is suitable for adults in non-emergency situation, and this is the best one in emergency, which is the green colored. And you have an extra one, which is the gray colored one. This is more suitable for emergency situations. Then you have to follow up the pulse, the blood pressure, the respiratory rate, which is the vital signs of your patients, and you can start to give warmed crystalloid, and this is the first line in the resuscitation after doing this insertion of this cannula. You have to guard the airway, which is the breathing and circulation, which are called the ABC. This is mainly with patients having hypovolemic shock or clinically shocked, and this happens in major attacks if you're going to lose more than 1 liter of blood. You have to adjust the position of your patient, keep your patients almost always warm. You can use up to 3.5 liters of isotonic crystalloids, and you should be ready for transfusion of packed RBCs. And remember almost always not to use this hydroxyethyl starch, because this will cause low platelet count and it may aggravate the problem of blood loss. So remember almost always to use this crystalloids and be ready for arranging a transfusion of packed RBCs or blood broth. These are the types of fluids that could be used during this problem. You can use crystalloid, and this is the best one. It is something like isotonic crystalloid. Colloids is another example, where the most famous example is starch. And again, don't use this starch in critically ill patients having these bleeding problems. You should have packed RBCs, fresh frozen plasma, platelet transfusion, or cryoprecipitate, and these products mainly used in patients having the problem of DIC or disseminated intravascular. This is an algorithm of management of patient having major postpartum hemorrhage. If there is a loss of more than 1 liter of blood, the first thing is to call for help the senior obstetrician and the senior anesthesiologist, hematologist. All these should be in theater. the first step after that, you have to do resuscitation. You have to guard the airway, breathing, circulation, use oxygen mask, and start fluid transfusion, and be ready for transfusion of blood. If you don't have this cross-matched blood, you can use O negative blood for resuscitation. The blood products again is used in patients having the problem or suspected to have DIC. The second step after that is you have to to insert this 14 gauge cannula. Again, this is a green one or a grayish one, and take this CBC and this cross-matched blood. Then you have to try to use this medication for the treatment. This is a medical treatment before doing any intervention, and this is mostly for patients having atonic postpartum hemorrhage. You can do massage of the uterus, try to empty the bladder, use oxytocin 5 international unit. You can use ergometrine up to 0.5 milligrams. Oxytocin could be increased up to 40 international units. Carboprost, which is a prostaglandin F2 alpha, this is another analog of prostaglandins, could be used in 0.25 milligrams, that it can be used up to 8 times. Again, carboprost is a prostaglandin analog, prostaglandin F2 alpha. This is another prostaglandin analog, which is misoprostol. If you remember, we talk about the prophylaxis by using misoprostol. It was about between 200 up to 400 micrograms. It could be increased up to 800 micrograms in patients having this major problem. And this then consider to give tranexamic acid, which is a non-specific hemostatic. It could be given by 1 gram intravenously. If these medications succeeded to control the problem, it's okay. If you are not able to control the problem after giving this medication, you have to transfer your patient to the theater, and by this you have to try to do temporary techniques like intrauterine balloon tamponade, or to do interventional radiology. If this balloon tamponade succeeded to control the blood loss, it's okay. If you cannot, you have to do intervention in the operating theater. You can do uterine devascularization, I mean ligation of the uterine arteries, ligation of the internal iliac arteries, and the last step is to do hysterectomy after failure of all of the previous measures. This algorithm again is recommended by the Royal College of Obstetrics and This is to sum up what we have said. You have to have a venous access, catheterize the urinary bladder, massage the uterus, and you can use most of these drugs. These drugs including centometrine, oxytocin, ergometrine, misoprostol, carboprost. Again, carboprost is a prostaglandin F2 alpha, and it has major side effect, which is a bronchospasm. That's why it's not preferred to be used with patients having bronchial asthma. Ergometrine could be increased up to 2 ampoules. And again, the main side effect of ergometrine is the hypertension. Remember almost always that oxytocin has main side effect of arrhythmia, and you can use non-specific hemostatics like tranexamic acid. Then you have to do technique before going to the operating theater. These are the medications in the market. Here is an example of the misoprostol, is a prostaglandin analog. This is an oxytocin. This is imethorgine or ergometrine. Again, this one is a carboprost. It's not used in the treatment, it's used in the prevention, which is an oxytocin receptor analog. This is how we can deal with patients. If it is mild attack, mostly of these patients will respond to medical treatment and massage. If it is moderate or severe attacks, ecobolics and the massage also can solve the problem in moderate attacks. But if it is severe, you may be in need of exploration or transferring your. If you are losing more than 25% of the blood loss after resuscitation of the patient, you can do these temporary techniques. This is a bimanual compression of the uterus. You can insert one hand in the vagina and the other hand in the suprapubic area to compress the uterus between both of your hands, and this again is a temporary technique. This is another technique, which is a compression of the abdominal aorta itself, and this is done mainly for thin patients. And you can do also uterine backing, or we have another is important. This is how to do the bimanual compression. Again, this closed fist in the anterior fornix, and this is in the suprapubic area, and we're going to compress the uterus between both of you. Here is a minimally invasive technique, which is called interventional radiology. We can use this catheter through the femoral artery to embolize the uterine artery or to occlude the uterine artery. After doing this technique without without doing surgical maneuvers, and ولكن it is mostly needs high cost and it's not available in most of centers. This is another option, is to insert this balloon inside the uterine cavity. This balloon will be inflated. After inflation of this balloon, you have compression over these bleeding sinuses, and this balloon should have another balloon here in the area of the cervix to prevent its sluggage. And these are examples of different examples of the balloon that could be used. This is a Sang-Staken balloon which is used in our locality. It has one balloon in the upper end and another one is inserted here to prevent its slippage from the cervix. And this is the Bakri balloon, which is a very famous one, Bakri balloon, which we use almost always in the first step prescribed in patients having postpartum hemorrhage. This is the devascularization of the uterus. We can ligate the uterine artery bilaterally, and this prevents about 50% of the blood supply of the uterus. And then you have to ligate the internal iliac artery, and this prevents about 80% of the blood supply of the uterine artery. This is how we ligate the internal iliac artery. Suppose this is the internal iliac artery. Here, this is external iliac artery, this is the internal iliac artery, and this is the external iliac vein. This artery is our target, is to ligate this artery by doing this right angle, and this is how we tie this stitch. Then we have this compression suture. It is called B. Lynch suture. The scientist who discovered this suture is called Christopher B. Lynch. Is going to bypass this suture anteriorly and rotate it posteriorly to the back of the uterus to compress between both of the uterus after tying this stitch. This is described at 1997, and the uterus here should be open to do this classic approach, and this is the final shape of the uterus after doing this compression. It is done by an absorbable suture. It is not a permanent suture. And again, the last step is doing supravaginal hysterectomy, and it is the last option if all of the previous measures is going to fail, and if you are not willing to preserve the fertility of this patient, the last step is to do this emergency hysterectomy. Here is another device. It is used in the OR. This device is something like the dialysis machine. Is called the cell saver device. This device is going to take the blood that is coming out from the patients or from the field. It's going to bypass through this machine to be filtered, and the waste product is going to be out of the patients, and this blood is going to retransfused again to the patients by its own blood. The main advantage of using this machine is that you are safe as regard this massive blood transfusion, and all the complications of incompatible blood transfusion is prevented by this machine, which is called cell saver device. This is to sum up the main 4 T's of the patients. It could be trauma, tissue, thrombin, tone, and for tone, this is uterine atony, and these are the measures that we talk. For thrombin, remember coagulopathy, and this is the coagulation effects. For the tissue, we have retained tissues or placenta accreta, or for the trauma in the episiotomy or in the genital tract. These are to sum up the causes of postpartum hemorrhage and how we deal with each one. On the other hand, we have what we call secondary postpartum hemorrhage, and again, this happens after the first 24 hours of delivery, and it could be extended up to the first 12 weeks. And this could be due to retained product conception, infection, submucous fibroid, very rarely choriocarcinoma, inversion of the uterus, local gynecological lesion like cervical erosion or cancer cervix, or estrogen withdrawal bleeding. Here we will try to give you a summary of what can we do with these patients. At the start, if you have a severe attack of secondary postpartum hemorrhage, you have to be ready for blood transfusion. If you have retained the product conception, you have to give ecobolics and try to remove this retained product of conception under anesthesia. If you have signs of sepsis, you can try antibiotics. Submucous fibroid could be removed vaginally. Choriocarcinoma, cancer cervix, or acute inversion treated according to each one. This is an example of how we remove this retained product conception under anesthesia. We can try to remove this retained part. This is how acute inversion of the uterus happens. This acute inversion of the uterus happens immediately after delivery. The uterus is going to be inverted and coming out of the uterus. You have to try to reinsert it again in the pelvis, and keep your hand inside the uterine cavity and give ecabolics till the uterus will be firmly contracted over your hand, and this is how we correct the acute inversion of the uterus. This is the end of my slides, and thank you so much for your for this lecture.